Well, it's indeed my pleasure to be here, and I'd like to thank Dr. Glebe, Dr. McNeely, and Masterson Abshar. People ask, well, how did a pediatric urologist get into trauma? A little bit of a story. When I joined originally University of Texas Southwestern, I was the youngest staff member of then only 3 staff at UT Southwestern, and everybody else was famous and traveling. And I was the pediatric urologist and also then the person who was on call for all the trauma. So, so my dad told me, gee, if you just find yourself in a mess, you better find some way to improve it. So I just basically ended up saying, well, if I have all this trauma I have to see, I might as well start collecting data and writing about it. So this is how it started happening. And then I moved to the clinic, and I was the only one that knew anything about trauma. And so all of a sudden, as a pediatric urologist, any trauma that came in, I was called in for the trauma. So welcome to life. So what we teach here for our residents is for the pelvic fracture urethral injuries. If you have a pelvic fracture, there's something that we call a urologic triad. And if the patient has gross hematuria, blood at the meatus, or inability to void, then basically, if you have any one of these 3 findings, you have a 25% chance of finding a lower urinary tract injury. So the word 25% here, when you're looking at pelvic fractures, really comes into urology. So what we teach our residents here is the incidence of GU injuries with pelvic fractures. If you have one of those triads, is 20 and 5. So 25% incidence that you're going to have it. 20% will have a bladder injury only. 5% will have a urethral injury. If you have a urethral injury, 20% are going to have a concurrent bladder injury. 5% will have a bladder neck injury, which becomes very critical for the management of these patients. And 5% of pelvic fractures at our institution are compound or open fractures. So you have a rectal, vaginal, or skin laceration in the buttock or perineum that's direct communication with the pelvic fracture. And if you have that, you have a 20% chance of urethral injury. That's just a stronger shear force. So you can see where that rule of 20 and 25 comes in, just to associate things to throw our residents into what they should be looking at. Mortality of pelvic fractures. I mean, the whole thing is you don't want people to die. It's really related to the type of pelvic fracture because, again, you have associated injuries. But if you have an open fracture, that's the worst one. If you have an open fracture, death is 50% in 1980. Now, it's decreased to 5%. That's a 10-fold decrease if you look at that in 2010. And if you say, well, gee, what happened? Death in 1980 and still in 2010, 2/3 of the patients will die from exsanguination. And what happened during this time span is interventional radiology. They really jumped in with angioembolization. 1/3 still die with an infection. And so again, if they have a rectal injury, the first thing that's going to happen is most of them are going to end up with a colostomy or ileostomy. But I'm going to point out a couple things here. For urinary diversion, usually it's okay to just put in a suprapubic tube, but as you're going to see in this talk, there are some times where that is definitely not enough to manage. Little historical perspective. 1930s to 1970s. In World War II, if you basically had a pelvic fracture, what they attempted to do, as long as you didn't exsanguinate, is they actually went in and operated and tried to sew things back together again. By the literature, they said it was associated with increased blood loss. Well, there's no angioinfarction, so they can imagine how much blood they were losing when they were doing this. Infected hematomas, increased risk of erectile dysfunction, increased risk of urinary incontinence. So with those things, it was pretty much abandoned in the 1970s. But then we started to see a lot of problems. So just to know right now, basically still a suture repair of a pelvic fracture urethral injury is still what you're going to pursue if you have a concurrent bladder neck laceration and urethral injury. So that's a situation where you're going to say, yes, we're still going to do something openly to try to fix this. What about urethral realignment? Initially described in 1932. The ways we used to do this predominantly at Parkland when I was there and when we first started was just, especially in the adults, put your finger through the bladder neck, put a catheter on a Mandarin sound and drive that catheter right to the tip of your fingertip and drive it in. Fortunately, we developed endoscopic instruments that were now very nice and flexible, so they work great, but not in kids. In kids, it's still a significant problem if you're going to do a urethral alignment in a young child. It really fell out of favor because of 2 papers, Mitchell in 1968 and Morehouse in 1968, made these comments. Erectile dysfunction, if they did a stage repair, put in a suprapubic tube and did a stage repair, had an erectile dysfunction rate of 3. In their patients, when they looked at it, if they had done a realignment, 33% of their patients had erectile dysfunction. That's a 10-fold increase with urethral realignment. They also said that urinary incontinence in a staged repair was 2 to 3% versus 4 to 6% with realignment. So a 2-fold increase. So in 2 papers alone, they basically killed urethral realignment for most places in the United States. It's very interesting. What was happening during this time span, you were collecting all this data. If you put in a suprapubic tube alone and you do a delayed reconstruction, you're going to obliterate that urethra in 90% of the patients. And what they were missing is really experts needed to do these repairs. This wasn't something that you could simply do. So there's a big concern saying, oh, we're not sure we should be doing this. And I have to credit Dr. Webster and his colleagues at the University of Virginia. And Webster and Jordan at that time decided they weren't biting into what had been published and started basically saying, we're going to realign people and see what happened. And what they found out has subsequently been confirmed by multiple authors. We took Webster's data and did it at Parkland starting after they published a paper and said, now we're going to do urethral realignments and see what happens. In essence, erectile dysfunction is no difference. It's much higher than what had been previously reported, especially since you can do shim scores. You have a pelvic fracture, likelihood you're going to have erectile dysfunction is about 40%. Urinary incontinence, no difference if you do it versus suprapubic tube, stage versus endoscopic realignment. It's about 5%. It's not necessarily at all related to what happens other than the injury. Do you have a bladder neck laceration? Have you had a concurrent sacral nerve damage? So what has been found out when you start comparing all the literature and looking at it is the incidence of complications is related to the primary traumatic injury, not the method of repair. And this is my own personal experience with what we've done for the past 30 years. You look at this here, PST, primary suprapubic tube versus endoscopic realignment. If you look at that for the obliterative strictures, we match what's in the literature for primary suprapubic tube. 90% of our patients end up with an obliterative stricture. If we do an endoscopic realignment, 60%. Even though we have the catheter pulled, we'll pull it out. The fastest I've seen that close, 36 hours. I've had one that we pulled, still had a suprapubic tube in place. Basically, the person was unable to void and totally obliterated. So it can happen extremely rapidly. It's said that if you do an endoscopic realignment, the surgery is easier. I can't say that's true. We get success rates equivalent with the both. I don't think it's easier if you do an endoscopic realignment. Partial strictures, so when you pull the catheter out and you see somebody slowing down, or that they can pee through there, 5% with primary suprapubic tube. In our experience, 30% with endoscopic realignment. What you're going to see here, you've got a partial obstruction. That does allow you to manage that with endoscopy, so you don't have to do a big repair. But for us, basically, 30% of our patients managed this way are still on intermittent dilation to maintain patency. And you can see there that we actually had no treatment, or we just did 1 DVIU in 5% of our patients with primary suprapubic tube, 10% for endoscopic realignment. So is there an advantage to endoscopic realignment really over in a pelvic fracture urethral injury? Well, you reduce obliterative stricture by 30%. However, in that 30%, 2/3 of them, you're maintaining that urethra by repeated urethral dilation, repeated DVIUs, where they're daily passing a catheter to keep that channel open. True success in our hands is less than 10%. Less than 10%. In contrast, if you do a suprapubic tube alone and do an open repair, 5% of our patients need to maintain patency by repetitive DVIUs or urethral dilation. You kind of argue yourself how well it is. True success, in other words, we did nothing but put in the suprapubic tube and the person does fine, only occurs in 5%. So that kind of is the background. What do we recommend for pelvic fracture urethral injuries? If the patient is stable, we will give a brief trial of an endoscopic realignment. What we do for this is basically the resident gets 5 minutes to get it across. So we give the resident the flexible scope. We give them a glide wire. They're set because you may have one good view where you can see something to get it across. They get 5 minutes while we're watching them on the camera. We get 5 minutes, and then we're done, and we're on to a primary suprapubic tube. We're not going to waste a lot of time. You're filling a lot of that pelvic fracture with a bunch of water that's not necessarily the sterilest in the world. Can get an infection. You already learned that that's one of the main things these guys die from. So we'll bail out and go immediately into suprapubic tube. One thing here, the bladder neck lacerations and pelvic fracture urethral injuries, that's a whole nother ball game. These people are frequently exsanguinating, so a lot of times they'll end up getting one, if not both, hypogastric arteries with angioinfarction. A lot of times we're not even asked to manage these people because they're trying to save them for their lives till they're 2 days down into the injury. We'll go in and we'll try to do a bladder neck laceration repair, and we'll actually do a suture repair of that urethra of that bladder neck. It sounds terrible, but in all honesty, it is unbelievable vision. That pelvis, before the orthopods get there and start to crank things together, man, you can put your head, I could pick up your junior resident and lower him into the wound. I mean, it is unbelievable vision, better than any transpubic urethroplasty you've ever seen in your life. And the only thing that's bad about it is you can see here, I would love to tell you that I know how to repair the bladder neck. Look at my continence rate. 0. 0. So I have some that have wear some pads, but a lot of them are diaper dependent. But our pelvic abscess rate by doing that is 0. Watch this. There are some that we got in and we had so much necrosis of the bladder neck, and we were putting our stitches in and they would not hold. I mean, you could just put them in and you could see them just fall apart, put them in and fall apart, put them in and fall apart. So then you're left with this individual that's got a bladder neck laceration. You've tried to reapproximate it. You can't get your sutures to hold. They're really a mess for us. A lot of times we put a big suprapubic tube in, we put a urethral catheter in, we tried to realignment, we put big pelvic drains in, and as you can see there, we still got 62% of these people with huge pelvic abscesses. 2 of them I'll forever remember because they developed pelvic fournieres, not perineal fournieres, pelvic floor fournieres inside. They both fortunately survived, but they were very difficult to take care of. So the bladder neck lacerations where you can't repair because of technical problems are a real problem. Now we know to put in bilateral percutaneous nephroscopy tubes in those individuals. You got to, again, proximally divert them. So after we looked at this data and said, what should we have done? We became smart enough to say, when you can't do this, you've got to get the urine out of the pelvis. So urethral stricture, I'm kind of switching away from the pelvic fractures. So let's look at data in the United States. So we can get at the National Insurance Data Banks in the United States. So this is urethral strictures. National data banks, we're seeing what they're charging. Information also, we surveyed all the AUA members, 35% response rate. Also, we went to the Board of Urology and said, let's look at all the practice logs that people are submitting, either for their initial certification or recertification. So, this is the data from that. In the United States, incidence urethral stricture in men, 0.5% of men greater than 20 years of age have a urethral stricture. 96% of the urologists at the time of certification or recertification has treated a urethral stricture. How did they treat them? 94% of strictures were treated with DVIU or uretrodilation. 6% were treated with a formal urethroplasty. So uretrodilation DVIUs are the predominant way to treat strictures in the United States. Thought this was interesting. Multiple states had no patients, 0 patients undergoing a urethroplasty. Basically, 8 states have nothing. No one charged, no one did an open urethroplasty in these 8 states. None. 0. Initial certifying urologists, 12% had done at least 1 urethroplasty. Recertifying urologists, 4 had done a urethroplasty. Combining the certifying and recertifying urologists, 6% had done greater than 5, and that's in orange because this greater than 12 is going to become key in a little bit. 1% of urologists had done greater than or equal to 12 urethroplasties per year. Now, my dad was a master electrician and plumber, so he traveled throughout the Midwest basically building shopping centers and left us in a small town in Nebraska. Beginning at 12, he made me tag along with him. So he grabbed me by my hair, basically. At that time, I had hair. And he basically dragged me along and would send me to work. Basically, he'd go inside and work and kept me running back out to get his tools for him. And his statement was, if all you have in a toolbox is a hammer, then, I don't know how many times I heard him tell me this, regardless if it's a screw or a nail, you will drive it home with a hammer. And to bring that point up is I think a lot of urologists have no idea how to do an open urethroplasty, or are very poorly trained in how to do an open urethroplasty. So what do they know to do? They know how to do the DVIU. And they keep going DVIU, DVIU, DVIU. So why the reliance on this? Is it the patient's choice? If you have a discussion with them, open urethroplasty versus internal urethrotomy. Is it the ease of the procedure for the surgeon? Is the surgeon unfamiliar with the open urethroplasty? Maybe internal urethrotomy actually gives you good results. Maybe open urethroplasty gives you poor results. Maybe there's increased complications. So, if you're going to be looking at urethrotomies and trying to do this, you need to know how this works. So wound healing, when you do not sew the skin margins together, heals by two processes. Epithelium has to touch. As soon as the two epithelial margins touch, then they basically have an epithelial mesenchymal feedback and the mesenchyma stops growing. So you have to get the epithelium to touch. If the epithelium doesn't touch, you get wound contraction. The mesenchyma keeps closing, trying to get the epithelial cells to touch. Scarring or stricture occurs when wound contraction is needed to cause epithelial approximation. So success, basically, of urethral stricture is dependent on two factors. Epithelial growth has to do better than the wound contraction. And you have to have no additional damage to the corporal spongiosum. Well, gee, you have to say, well, I don't want this urethra to contract. So a lot of people say, well, what about an indwelling catheter? Maybe that can help. Oh, well, you put that indwelling catheter in. I asked the residents, if you do a DVIU urethral stricture and you dilate it, why do you leave a urethral catheter? It's always interesting to see the response, because a lot of them don't know. The doctor said so. Staff told me to put this in. What the deal is prevention of extravasation of urine into the spongiosa and scar extension. That's why you're putting that urethral catheter. You don't want urine into the spongiosa. You also don't want it to cause additional damage to the spongiosa. Urine in the spongiosa causes fibrosis. Some people believe that urethral catheter is going to hold that incision open to combat wound contraction. They think that's going to encourage the epithelium to make contact. However, there have been absolutely no studies regarding this. None. And I'd have to say, I'd be concerned because I think that foreign body actually may decrease the epithelial growth. We do not know this. So, here's a question. Does the length of the catheter left in situ make a difference? And the second question is does the catheter size make a difference? So before I looked at this, back when I was a resident, a lot of times some of my staff would say, put in the biggest catheter possible, right? Find that biggest catheter in there, do that DVIU. Is that a 24? Is that a 26 French catheter? Put that thing in there. Let's study this. Actually, if you leave that catheter in 4 days versus 3 weeks, the outcomes are identical. Identical. The bad thing about it is you leave it in over 3 weeks, you actually increase your stricture rate. Where do you increase your stricture rate? Not where the stricture was. Always ask the residents, what are the 3 tight spots of the urethra? And they are the meatus, the bulbomembranous junction, and the bladder neck. The tightest of which is the meatus. You leave a big catheter in place for greater than 3 weeks, where does it develop a scar at? At the meatus. Nice paper showing that anything over 3 weeks, increased risk of scar tissue long-term wise for meatal-based strictures. Does that catheter size make a difference? Again, we're saying, bigger the catheter, the better, right? 16 to 22 French, identical outcomes, no difference. Leaving that big catheter in absolutely caused harm. Not by increasing strictures at where you had the stricture, but again by increasing the stricture at the meatus. So let's look at some really success of urethral dilation, urethral wound healing. If you're going to dilate somebody instead of doing an internal urethrotomy, that urethral dilation disrupts the scar tissue. You have no idea where it's going. It's like taking a ramrod and it's separating it, and it can be making stellate fractures all over the place. It can make one laceration. You have no control. Depth of the corporal injury increases the stricture. So I think you have better control with an internal urethrotomy than you do with urethral dilation. One thing people don't know overall, which you probably should, if you're dilating a urethral stricture, if you go beyond 24 French, you actually cause an increase in corporal bleeding. Corporal spongiosa bleeding increases the stricture, and we know if you dilate beyond 24 French for urethral stricture, you actually increase the stricture length. Now, the residents, if you're smart, you're going to immediately say, well, why do we dilate that urethra for that resectoscope? And you're going to go a lot wider for the resectoscope, but that has been shown to, if you dilate wider for your resectoscope, to actually decrease the incidence of urethral strictures because you're rubbing back and forth. So treatment of the stricture versus what you're doing prior to putting in that resectoscope are two different things. Key here, if you're going to treat a urethral stricture with dilation, don't go over 24, and you really want to finish that dilation and have minimal to no bleeding. If you have bleeding, you've actually done what you don't want to necessarily do with that dilation. So how do you perform an internal urethrotomy? Two main thoughts. There is a third thought that's out here that I have zero experience with, but you can do a single linear longitudinal incision control plane at 12 o'clock, which is what I like to do. But there are also two incisions that you can perform at 4 and 8. We're going to go over what we basically seen some differences with that. Another method that's out there that I have to say I have zero experience with is to see that stricture and to take that cold knife or that laser and to cut it like hands on a clock. Multiple small cuts in a radial fashion around there, getting it so it can be open without a big cut into any of the spongiosa. Well, what do you think here? Since we've done both methods, single incision at 12 o'clock and incision at 4 and 8, think one's better than the other? Just like pick your poison. If you cut at 12 o'clock, that's the thinnest area of the spongiosa. So why do we cut at 12? Well, you cut at 12 so you don't get bleeding into the corpus spongiosum. What's bad about cutting at 12? You can cut right into corpus cavernosum. Now, how do you treat priapism? If you treat priapism and you can't get it down with basically your pharmacologic treatments, you make a spongiosum cavernosum shunt. What did we just do if we cut that corpus spongiosum deep enough right into the corpus cavernosum? We just shunted them. So if you cut at 12 o'clock and you follow your patients up long enough, whether it's a kid or an adult, 3 to 5% incidence of erectile dysfunction by 12 o'clock cuts. 3 to 5%. What about cutting at 4 and 8? Saw this data as we were doing our stuff and said, well, I'm going to switch. I'm going to cut at 4-8. Pick your poison. So we started doing MRIs. There's no doubt when we did MRIs after we did a DVIU at 12 o'clock, we had less spongiosum. But we cut at 4 and 8, huge amount of bleeding into the corpus spongiosum. And what happened? We documented we increased the scar length from 80%. Documented we increased the scar length. So which way do you want to cut? Choose your poison. How good is it? Since this is what 96% basically of urologists use in the United States, how good is this? Well, this is our database. Again, this is our experience, so I'm only throwing stones at ourselves. Management of urethral strictures, 1986 to date. We follow a patient at 3 to 6 month intervals after we do this for 2 years. Everybody gets a flow rate with an ultrasound residual urine. We do a retrograde urethrogram and cystoscopy only if they have recurrent symptoms or an abnormal uroflow. And an abnormal uroflow for us, we define that as less than 15 cc's per second with 150 cc's voiding. How did we do? Well, here's part of our technique. We use it only for bulbar urethral strictures. They have to be less than 1 centimeters, and we are very picky. This is not the pinpoint urethral stricture. I have to have a 5 French whistle tip catheter fit through that stricture. If I can't get a 5 French whistle tip catheter to go through there, basically, I'm not doing a DVIU. That's another procedure. So we do our DVIUs at 12 o'clock. We leave a 16 French catheter in, variable between 4 to 7 days. If you ask why the variance, I say, when's the weekend? So it's kind of dependent upon If it's going to be classically 4 days, but if that 4 days is going to fall on a weekend, it's going to be the Monday or so afterwards. This is the data from 1986 to 2014. We broke up our patients in 2 different ways because, in the literature they said, well, clean intermittent catheterization after you do a DVIU is supposed to help. So we did some where we just did the internal urethrotomy. We did others where we did the internal urethrotomy, placed them to put an intermittent catheterization 1 time per day into their bladder for 3 months. At the end of 3 months, we stopped. We counted success by the last instrumentation. So we're following them 2 years. So if you really look, it's 2 years for the DVIU. It's 2 years and 3 months because we're going after they had stopped the instrumentation for the intermittent catheterization group. Absolutely no difference. That addition to that intermittent catheterization, all it did was delay when that urethral stricture came back. It did not improve the outcome. So we saw no improvement by doing an internal urethrotomy and then starting the intermittent catheterization. What about if that failed? What did we do? We went, and if the stricture was less than 1 centimeter and still less than 5 French, we did a second DVIU. So we had a 20% success rate with the first. We got about a 25% success rate with the second. But oh, by the way, 2/3 of our patients, we significantly lengthened their stricture rate. Significantly lengthened their stricture rate. Of the ones that failed 2 DVIUs and went to do a third, none of them worked. None of them worked. So that's basically saying we get patients sent to us where I am right now to manage them. Most of the patients that I'm seeing have on DVIU 5, DVIU 6, especially the kids for hypospadias repairs. A lot of times before they get to us, they're on a urethral dilation 4, 6, very, very far along. So what happened here, if they failed their DVIU, if they failed the second one, we went to a dorsal buccal graft urethroplasty. In our hands, a dorsal buccal graft urethroplasty, after 2 internal urethrotomies, had a 90% success rate. After 3 and 80%, that's actually no statistical difference there. It would be nice to say the more you actually instrument them, the worse our outcome is for a buccal graft, and we can't prove that. We can't prove that. We're always banking in that 85 to 90% range. If you fail your buccal graft, what do you do? So it's a small stricture. We've actually done a urethrotomy again. We've had, as you can see, N equals 1. We've had 1 success rate with that. We've actually repeated buccal grafts in some. And in some individuals, we basically keep them on intermittent catheterization. So lessons learned. So we only do internal urethrotomies for a bulbar urethral stricture. It's got to be less than 1 centimeter in length. Diameter's got to be greater than 5 or equal to 5 French. If you do 1 urethrotomy, your success rate's going to be about 20%. If you do a second, we can increase it about 25. So for us, that's a 40% success rate with internal urethrotomy. That's twice what's reported in the literature. That may be because we're very selective on who we do our internal urethrotomies on. What do? If you do the second DVIU, you have to realize that 2/3 of the patients you will make worse. And there's absolutely no benefit to doing that third one. You should be shipping that person absolutely off to get repaired. Incidentally, people will tell you, let's inject, I've inject steroids in it. I haven't used interferon, botulinum toxin, or collagenase. Those have all been done. Nice studies show that they basically do no added benefit. All they do is delay. Our experience with steroids is they delay the recurrence of the stricture about 9 months to a year. So they don't cure it, they just delay it. I will have to say one thing here is I don't use the laser for this, but nice study by Barbagli basically showed there was no difference between a laser and a cold knife. Now, although I'm a big proponent of direct visual internal urethrotomies, is the urethral dilation worse? Is urethral dilation worse? The answer to that? Results are identical between the 2 methods. Identical. So, in the only 2 studies comparing them head to head, they were the same. So even though I'm a huge proponent of an internal urethrotomy, if you say you want to dilate these individuals, we can't prove it's a worse method. So what do we do? Well, if we have a bulbar urethral stricture, we do a stair-step approach. If it's less than 1 centimeter and greater than 5 French, we'll do a DVIU times 1. Success rate's about 20%. If it recurs and it's still less than 1 centimeter, it's still greater than 5 French, we'll repeat it with a 20% success rate. If it's a urethral stricture greater than 1 centimeter, recurs after a second DVIU, basically we'll do an open urethroplasty and our success rate's about 90%. And again, although we're big believers in internal urethrotomies, we can't, I know I'm repeating this, we can't say that dilation gives you any different results. What else do we do? Well, if it's less than 1 cent but less than 5 French in diameter and bulbar in location, we'll immediately jump to an end-to-end, and our success rate's about 90%. I'd like to say it's higher, but that's what we range. By the way, we'll never do a penile end-to-end. Never do a penile end-to-end. We shorten the penis, put on stretch rate, we really have a problem. So in our penile less than 1 centimeter, so anybody that's greater than 1 to 5 centimeters, we'll either do an inlay graft or a flap. I personally now have pretty much switched all to grafts, but we have done both in the past, as you're going to see. If it's greater than 5 centimeters, we do a staged buccal graft. Sounds good to say it's staged. 80% of the time, that's 2 operations. 20% of the times, it's more than 2 operations. You have to do different things to keep things open. If it's greater than 5 centimeters and they're adult, we'll also offer them the ability to do intermittent catheterization to maintain patency. Some will do that rather than saying that they want to go through all those operations. Well, a lot of them, it's amazing, even 30 and 40-year-olds will basically say, no, I'd rather have a perineal urethrostomy, let me be. And absolutely, we have a lot of 30-year-olds that have perineal urethrostomies that have failed multiple hypospadias repairs. Surgical success. This is what I was mentioning about before. This is data predominantly coming out of England. I think it's interesting for the residents to look at this. Success, so they looked at their surgeons in England. They found out that success matched public results after they had done about 45 to 60 cases. Again, a little independent variability there. But after they had done about 45 to 60 urethroplasties, you could match what was in the literature. However, you had to continue to do X number of cases per year to continue to match the results. Specifically in the British literature, they're finding out that you have to do about 12 to 15 cases per year to keep that result the same. So that's telling you here in the United States, if you remember right, 1% of urologists fell in that range. 1% of urologists. Graft versus flap. What's better? Well, flap. Here's the nice things about a flap. It carries its own blood supply. Bad thing about it is, wow, there's not a lot of skin that you can get that's going to carry its own blood supply and not have hair, so you're really limited to the prepuce. The graft. More volumes available. One thing that we've looked at ours, keeping all this data for us, is, man, it's really reliant on the graft bed for vascularization. So we have really good results with grafts, but I can tell you right away is there's some people that I will not put a graft in. What you see there in our hands looking statistically is what's the highest likelihood of failure. So tobacco was actually worse than previous radiation therapy. So if you smoke and I'm thinking about putting a buccal graft on you, I'll tell you I'm not doing this till you stop chewing or you stop smoking. It's not happening. So radiation therapy, I really thought that would be number 1, but looking at our data, it's tobacco. Diabetes mellitus, pulmonary disease, that makes sense because you're poorly oxygenated. Atherosclerotic coronary vascular disease, all these make fairly good sense. Obesity, because we have an increased incidence of infection, and a lot of the obese people are diabetics. So you're getting a double tandem. Steroid use, that one's a little bit harder for me to explain why that gives us poor results, but we certainly see it. Now, tubularized. Are you going to tubularize this? Isn't this a lot easier to not do this in a stage and do this all in one? Let's tubularize everything. How good is this? So for the pediatric urologist, you're going to probably identify this really fast because tubularized flaps basically is the old ducket flap. But single stage tubularized graft, I love this. Fell in love with this. Thought, wow, let's take this buccal graft, let's roll it around this catheter. I'm going to sew it in there. I have an opening. I'm going to tunnel it underneath the skin, poke it through the glands. It looks beautiful. Great operation. Technically, it looks just phenomenal. Look at those results. Man, why did it take me 22 cases to wake up? I mean, those are horrible. I mean, it's like, okay, I should learn that a tubularized graft is not a good idea. So I can tell you we abandoned that. That's out the window. How about a single-stage tubularized flap? Well, that's the pediatric urology, and that's the old island flap. That's the ducket. How well did we do with using a ducket flap for these? Well, statistically better than a tubularized graft. But look at that. 40% basically success with that operation. 60% of the time we had to do something else. So what do we do now? We are already saying, well, if we're going to have to do that many second procedures, let's do a staged buccal graft. And our success rate, you can see right there, is about 90%. So for us, that's the best outcome, but you're already biting into saying I'm doing multiple procedures. Switching topics a little bit here. Lichen sclerosis, or balanitis erotica obliterans. This is really a bugaboo if you deal with this, especially as I see a lot of hypospadias cripples. A lot of our hypospadias cripples have BXO in them when they're coming back. It's really a problem. We don't know what causes it, but the predominant theory right now is that urine has to infiltrate into the epithelium. And once the urine gets in the epithelium, you develop an autoimmune response to that. So that kind of tells you how you can kind of possibly treat this. Characteristically, you look at this, there's dry white areas on there. We'll ask the residents what it stands for. The lichen sclerosis heterotrophicus, or balanitis erotica obliterans, tells you what it stands for. So lichen means white, okay? Sclerosis, what's sclerosed or what's obliterated? The vessels. The capillary vessels and the arteries are obliterated. Well, right away, if you're going to put a graft on something that's obliterated, doesn't that sound horrible? Like a horrible concept. Atrophic, what's atrophic basically is the epithelium. It's not getting a good blood supply. The sclerotic layers are dermal layers. So, skin versus buccal graft on these. Is buccal really superior? Well, it's hairless. I don't use the lower lip. We can ask other people, but I personally don't like the lower lip. Some people love the lower lip. I'll use a cheek any day of the week. It's easier to handle. It's elastic. It's rich. Highly vascularized. We bite our cheeks all the time. So, I mean, it is highly vascularized. The advantage of this is it's got so many blood vessels. Remember that the lichen sclerosis heterotrophicus, all those capillaries and arteries are basically sclerotic. Well, you're putting on a graft that's got big blood vessels, some that don't have good blood vessels, and they line up. That's what's happening with inosculation. And what's going on there is the more capillaries you have to grow into, the better off it's going to be. Other thing, if you take your cheek and you actually look at it for immunoglobulins, a bucket load of immunoglobulins in your cheek, because you bite it and you don't get infections all the time, so it helps you stop infections. It's also water repellent. Your mouth is saliva all over. Now, as an aside, I'm not talking about this, but I think it's important if you do peds to realize there were a lot of old repairs called Matthew repairs, flip-flap repairs, brought up the skin up into the glands. If you see those as an adult, our BXO rates in those repairs when they hit 50 to 60 is astronomical. Astronomical, because I don't think that epithelium is used to handling the urine. Urine starts to infiltrate in the epithelium and we got a big problem. So I really like the buccal graft, but as you see there, it says rarely affected by lichen sclerosis. I've absolutely had BXO come back in my buccal grafts. And the literature says it really doesn't, but I have at least 3 that we have histological diagnostic proof that we have BXO back in our buccal graft. What do we do for treatment? Well, if lichen sclerosis is in the foreskin and that's all involved, we're going to excise the foreskin. If it's on the glands, what we do is we use steroids, usually betamethasone ointment, but we do it only for 1 to 3 months. If you do it beyond 3 months, it actually makes the BXO worse. After that, we're trying to get the water to not go into the epithelium, so we'll use things like A&D ointment. You can use Vaseline, but the whole idea then is we're having them apply that daily so that the urine does not go into the tissues. In the involvement of the urethra, we actually do a 3-stage repair. We cut out all the BXO first, see what happens, make sure the BXO doesn't come back. If it comes back, we're done. I won't put the buccal graft down. If it doesn't come back, we put the buccal graft in at one time and then come back and roll it in a tube. Some of these people end up with perineal urethrostomies, and we do offer some people CICs to maintain patency.